If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we look at the NICE updates published in July 2025, focusing on what is relevant in primary care only. Today, we just have two clinical areas to discuss: the updated quality standard on cardiovascular risk assessment and a new technology appraisal on dapagliflozin for CKD. Right, let's jump into it. There are only 5 updated quality standards on cardiovascular risk assessment and lipid modification, so let's have a look at them. Quality Statement 1 refers to the identification of adults who are likely to be at high risk of cardiovascular disease. What does the new statement say? It says that general practices should systematically search their patient records to identify people who are likely to be at high risk of cardiovascular disease. Using routinely collected data, practices can estimate someone's 10-year risk of cardiovascular disease using the assessment QRisk3 tool. What's different from the old guideline? Previously, the guidance said that if a person between 25 and 84 was flagged as having an increased risk of cardiovascular disease, we should offer them a formal QRisk3 assessment. Now the focus is to use a proactive, structured search of patient records to find those likely to be at risk. So instead of waiting for risk to be flagged, we now go looking for it. However, we have to be cautious and use clinical judgment, especially in groups which may have missing or incomplete data in their records, which can lead to the risk being underestimated. Let's now look at Quality Statement 2, which covers diet and lifestyle advice for primary prevention. What does the new guideline say? Someone with a cardiovascular risk of 10% or more should be given lifestyle advice, and this should happen within 3 months of the risk score being recorded. What's different from the older guidelines? The previous, now obsolete standard say that people should be assessed for secondary causes before being offered statins, and then they should get lifestyle advice before being offered statins. So this update simplifies and strengthens this advice. Everyone with a 10% risk of cardiovascular disease or higher should get lifestyle advice within 3 months. It's no longer just a before statin step. Let's move on to Quality Statement 3 on lipid-lowering treatment for primary prevention. The new guideline says that people with a 10-year risk of cardiovascular disease of 10% or more should be prescribed a high-intensity statin unless it's not suitable for them. If they can't tolerate statins or have a medical reason not to take them, then an alternative lipid-lowering treatment should be offered. The recommended statin here is atorvastatin 20 mg, which is proven to be effective. What's different? Under the obsolete standards, we were first advised to try lifestyle changes, and only if those changes were ineffective or unsuitable would a discussion about statin therapy take place. Now the emphasis is on timely treatment. If a person has a 10-year cardiovascular risk of 10% or more and they choose to start treatment, they should be prescribed a high-intensity statin straight away, usually atorvastatin 20 mg. There's no longer a requirement to try lifestyle changes first. While lifestyle advice remains important, it's not a prerequisite to offering statins. This change reflects stronger evidence that earlier intervention with statins in high-risk people can significantly reduce the risk of cardiovascular events. But let's remember other key considerations. For those close to the 10% threshold, we will need to use our clinical judgment. For trans people, we need to be aware that QRisk needs the biological sex, which may not reflect an individual's gender identity, so adjustment may be necessary. And for people aged 85 and over, atorvastatin 20 mg may still be appropriate, but we should consider factors like frailty, comorbidities, polypharmacy, etc. Quality Statement 4 refers to assessing response to lipid-lowering treatment. This one focuses on how we monitor people after starting or changing lipid-lowering treatment, such as statins. The obsolete guidance recommended that adults on a high-intensity statin should have a repeat lipid profile and liver transaminase levels measured after 2 to 3 months. The new quality statement broadens this. It now applies to all adults starting or changing any lipid-lowering treatment, not just those on high-intensity statins. This change recognizes that monitoring response and safety is important for everyone, not just high-intensity statin users. And let's remember that fasting is not required for a full lipid profile, which should include total cholesterol, HDL cholesterol, and triglycerides. And that, from these, non-HDL cholesterol and LDL cholesterol are calculated. Let's now look at the final quality statement 5, which focuses on secondary prevention of cardiovascular disease. The previous, now obsolete guidance said that people newly diagnosed with cardiovascular disease should be offered atorvastatin 80 mg, and that, if someone developed side effects, they should be offered a lower dose or a different statin. What's changed? The new guidance shifts the focus from prescribing a specific drug or dose to achieving a specific cholesterol target. It says that people with cardiovascular disease should have either an LDL cholesterol which is 2 or below, or a non-HDL cholesterol which is 2.6 or below. This is a move towards outcome-focused care rather than just prescribing a medication and assuming it's effective. So instead of asking ourselves, did we prescribe atorvastatin 80 mg? We now ask, has this person's cholesterol actually reached a level that protects them? Besides, using non-HDL cholesterol as an alternative to LDL is helpful when LDL hasn't been specifically measured or calculated. Let's remember that, for example, LDL may not be calculated in people with very high triglycerides. Let's now take a few minutes to go through the updated NICE guidance on dapagliflozin for chronic kidney disease. This updated recommendation replaces earlier guidance and reflects both new evidence and a broader treatment scope for patients with CKD. So what's changed? Under the previous guidance, dapagliflozin was only recommended for people with CKD with or without type 2 diabetes, but only if their eGFR was between 25 and 75. This meant that certain patients were excluded, for example, those with mild CKD and an eGFR above 75, those with eGFR between 25 and 45 with normal levels of albumin in their urine, and notably those without diabetes and without significant proteinuria. At the time, these restrictions were based mostly on the inclusion criteria of the DAPA-CKD trial, and also concerns that the size of the eligible population might have been overestimated. Now, with this update, things have shifted significantly. The new guidance states that dapagliflozin can be used more widely in people with an eGFR between 20 and 90, as long as certain conditions are met. For people with an eGFR between 20 and 45, no additional criteria are required. But for those with an eGFR between 45 and 90, they must also either have type 2 diabetes or have a urine albumin-creatinine ratio, or ACR, of 22.6 or more. So this new recommendation includes a much broader group of patients, especially those with early-stage CKD and diabetes, or those with elevated proteinuria but better preserved kidney function. Why has it changed? The change is due to new evidence including meta-analysis and indirect treatment comparisons between dapagliflozin and empagliflozin. While these two drugs haven't been directly compared in a clinical trial, the available data suggests that they are similarly effective and safe for people with CKD. Also, the cost of dapagliflozin and empagliflozin are comparable, so there's no financial reason to prefer one over the other. As a result, NICE has aligned the eligible population for dapagliflozin with that of empagliflozin, creating a consistent and flexible approach to SGLT2 inhibitor use in CKD. It also reflects a more inclusive and practical approach, one that gives patients better access to effective treatment and gives clinicians greater flexibility when choosing between dapagliflozin and empagliflozin. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.